Belly fat and menopause. You're not happy with your body. All of these changes, it feels like you've been doing everything you always did, but your body composition is changing. Maybe you've wondered, is this inevitable? And what can I do? Why is this happening? You're not going crazy. It's not all in your head, and there are solutions. We're going to talk about the approach you can use for your diet, supplements, exercise, and for those of you who are interested to learn more about hormone therapies. Dr. Mary Claire Haver is a board-certified OB-GYN. She is a New York Times best-selling author of the book you must pick up. It's called The New Menopause. And she's gone viral on social media, and thank goodness, because without someone like her and many of the other warriors we've had here on the show, like spreading the word, how would we know these things? Because unfortunately, most of our practitioners are not up to date when it comes to treating women's health and more. Without further ado, my friend, Dr. Mary Claire Haver. First question. Am I destined to deal with belly fat and just a different body as I enter menopause or postmenopausal?
Most women are, by and large, and it doesn't have to happen, but most women will gain weight with age, regardless of their menopause status. So whether you're menopausal or not. So remember, the average age of menopause is 51, but women go through between the ages of 45 and 55 under the normal curve, so 95% of women.
Yeah.
So you're going to gain weight regardless of at 45, 55, 65, whether or not you are in menopause. But the type of weight you're gaining is very different. So what happens in menopause, you take the premenopausal woman, and she, by and large, has a visceral fat level of 8% of her total body fat is visceral.
So when we're saying visceral fat, meaning the fat around her organs or midsection?
Intra-abdominal fat.
Okay.
So it's the fat that's under the muscle that's wrapping around our omentum, our gut, our liver, sometimes pericardial, but mostly in the intra-abdominal cavity.
So when she's perimenopausal, a woman has about 8% of her overall body fat.
So yeah, before, she's probably early peri. So
Okay.
about 8% of her overall body fat will be in and amongst the abdomen, and that's a healthy amount. We need some there, right?
Yeah.
However, you take the same woman, now you age match all these women, and you just measure visceral fat in someone who is the same age as her but happens to be postmenopausal.
Okay.
Right? It's 23%.
Just visceral.
Just visceral. So with no changes in diet and exercise, a woman can expect to about triple the amount of visceral fat that she has. And I don't have to tell a woman that. She comes in complaining of it to me.
Absolutely.
So does this have to happen? No. And there's definitely behaviors, nutrition, movement, hormones that can attenuate that.
I
But
hear
most women, if they
oftentimes-
do nothing different, like what kind of kept them in shape and healthy in their 20s and 30s, isn't going to work anymore.
Which is so discouraging for women who are reporting, self-reporting obviously, I'm doing everything the same. If anything, I'm eating less. I'm exercising as much as I did before. Don't tell me I'm not moving. I'm doing all the things. And I'm gaining this body fat. Even if they're not gaining weight, they can feel that their body is very different. And it's depressing.
Right.
Which we know that there's an increased rate of depression, anxiety in. But what came first? The weight gain, the distribution of our body fat?
It's the hormones that usually are coming first.
Okay.
So she's starting to undergo kind of a hormonal chaos in perimenopause, followed by a complete flatlining of her estradiol production. And that is causing the shift of fat into the intra-abdominal cavity, where she really, for most women, they really weren't gaining that much weight there before. That is typically where men gain weight, the beer belly.
Yeah.
And so all of a sudden it starts happening to females as well. And so cosmetically distressing, of course.
Of course.
We hate that, right?
Right.
All of a sudden you've had a tiny waist and now it's expanded. But more importantly, from a medical standpoint, this visceral fat is biologically active. It is pro-inflammatory.
What does that mean, biologically active?
So subcutaneous fat is the fat we've known our whole lives. That's the fat under our skin. It gives us breasts. It gives us hips. It, gives, in our face. Sure, we have some in the abdominal wall as well.
Yeah.
And we don't like it. It's cosmetically distressing. We were trained, especially our generation, because we're roughly the same age, of, thin is healthy, and we don't want that kind of fat and try to be as thin as possible. Thank God my kids' generation, they embrace their curves. Most subcutaneous fat can be very healthy, even though it just makes us different shapes.
Right.
Intra-abdominal fat is different. So subcutaneous fat is not nearly as biologically active, meaning making chemical mediators.
Okay.
Than the fat inside the abdomen is very different. That's why we call it different. That's why we call it visceral.
Yes.
That fat produces cytokines, which are chemical signals that increase inflammation. There are chemical mediators created in this visceral fat, much higher levels than would be in subcutaneous fat. And visceral fat is correlated much more strongly to your risk of chronic disease like hypertension, diabetes, stroke, etc.
How exciting. So we are putting on all this body fat around our midsection. It's a detrimental type of body fat, and it's having an impact on all of our human systems.
Yeah.
It's putting us at risk of mortality, of cardiovascular disease, of all these other things.
Right.
Are we destined to be this way? Is this automatic? And is it if it's because of hormones, is that one of the ways that you suggest that women mitigate?
So we definitely know from studies that women on HRT have a lower accumulation of visceral fat. But I don't feel like it's a magic bullet. I feel like it's one tool in your best health toolkit.
Yeah.
So hormone therapy, yes. But what if you can't take it or you choose not to take it? What else can you do? Well, I've dug into the studies done on menopausal women, which are not that frequent, but I found some.
Yeah. And
women who consistently get 25 grams of fiber or more in their diet per day have less visceral fat accumulation. So why would that happen? So fiber in the form of fiber-rich foods has a wonderful effect on our gut. Feeds the gut microbiome. That is the prebiotic. It's soluble fiber. It pulls water into the gut, so it increases the transit time through the colon. It also slows down the absorption of sugar into our bloodstream at a more steady rate. So when you eat something fiber-rich, you don't get as big of the spikes of sugar, so your insulin levels stay lower, and that just makes everything better long-term. So that's why they think that that's happening. And when your insulin levels don't spike and your blood sugars are lower, you automatically have lower inflammation levels.
I know it's a multi-pronged approach. It's something that I love about your book is you're very honest about there are no magic bullets. It's not just diet. It's not just your exercise. It's not just supplements. It's not always hormone support, but it's a whole host of these things. And it starts with us understanding how and why this is happening because, correct me if I'm wrong, most medical doctors have very little training.
I had no training in this. I had to go outside of what was presented to me as important.
As an OB-GYN?
Yeah. So I had 1 hour of menopause training in medical school. And I think I had a total of 6 hours of lectures that were loosely associated with menopause and a 4-year OB-GYN curriculum. We did not have menopause clinics. We did learn about hormone replacement therapy and some of the cardiovascular benefits, but it was very early when those discoveries were made. And then in the end of my last year of training, the Women's Health Initiative results were released, scared the whole world, including all the doctors, off of hormone therapy because of the perception that it was so dangerous. And effectively, I didn't learn anything else about menopause after that other than don't give hormone therapy unless there's nothing else you can do for her. And she's, her hot flashes are so debilitating. It's a last-ditch effort.
Explains so much. So if I am understanding you correctly, you finished medical school and you've learned what you've learned in medical school. And beyond that, it's up to the individual practitioner to...
So the American Board of OB-GYN, so if you're board certified, which hopefully your physician is, you undergo to recertify each year. You have to read a series of articles and then take quizzes, to make sure you read them. And it's about 40 articles per year. And we get to pick and choose a little bit about areas we like to specialize in. But there's no menopause section. I mean, I went through for about 10 years and dug through the journals to see how many menopause articles that there were presented to us as cutting edge new information. So the board recertification is meant to keep us up to date on some of the latest findings. Because a lot of docs struggle to keep learning once they get out of school and training programs. It just, life gets in the way. You're having kids, you're having a practice, you're doing all the things. And so the board recertification is kind of a way for you to get your continuing medical education credits and keep up to date on the latest information. However, the American Board of OB-GYN has chosen for decades not to feature menopause articles, not to insist on rigorous menopause training. So I got out of my training program, and I'm so proud of what I learned. I don't want to knock what I learned.
I understand, yeah.
delivering babies, surgery, pediatrics, oncology, all the things.
Important stuff.
Important. But then there was just a gap of a lack of menopause education. So where I am today, versus where I was 8 years ago was a conscious decision for me to go outside of the box and not rely on the status quo and realize that we can do better.
So with that in mind, because your primary focus of your practice is helping menopausal women, what do you find is some of the most common narratives? The woman who is like, I'm gaining weight, I'm not sleeping well, and I just feel thick around the middle. Doc, what can I do? What is she being told by her GP?
And these are things that came out of my own mouth, which I'm saddened and ashamed, but I feel like it's important that I'm honest because it will help the patient out there listening understand that I was a victim of lack of education and training.
Yep.
And so I didn't know what I didn't know. And that's my mission now, is to spread the word as far and wide as possible. But, what we were taught in medical school is the fat gain is calories in, calories out. That's it. We did not know the nuances of how nutritional choice and inflammation, nutritional deficiencies, aging, menopause, hormones, how that all affects. I knew kind of the rudimentary stuff about cortisol and estradiol, just very, very basic. But I had to go back and get secondary training in nutrition in order for me to really be able to wrap my head around and be able to counsel patients adequately about nutritional choice and how it could affect their lives. So that's another big gap that most healthcare practitioners have, is what's going on with nutrition and how it affects the human body and what it could be done preventatively.
So what are most doctors saying? If I go to my doctor,
work out more, eat less.
They'll say what?
Work out more, eat less.
Work out more,
eat less.
Eat less.
I said that for 15 years. And I did that to myself for 15 years. And what I was doing was calorically restricting and doing lots and lots of cardio and probably chipping away at my bone and muscle strength. I did not pick up a weight, Chalene, a serious weight, until 5 years ago.
Yeah.
I was running marathons, super proud of what I was doing. I was having fun with my girlfriends. I didn't start Zumba with hand weights till 5 years ago.
Wow.
I mean, we had a gym in my garage. That was for my husband.
Yeah.
I never really thought that much about weight training.
Yeah.
I did P90X because my girlfriends were doing it when we lived overseas for a couple of years. And, But, I was 8-pound weights.
Yeah, right.
That
exactly.
was it.
Yeah.
And so, what I tell my children, what I would tell my 35-year-old self, nutrition over calories, always, and strong over skinny.
So I'm thinking about that woman who has, been told this by her practitioner and also by society, right? And I was one of the perpetrators of the, work out harder, do more HIIT training, high intensity, high impact, pound yourself into submission as many hours as you possibly can, until I realized from looking at research, I couldn't figure out, why am I so inflamed? Why would I have a negative response to this? Shouldn't I have a lower incidence of inflammation if I'm conditioned to do this high intensity training?
Right.
So it wasn't until I was looking at the research of high intensity athletes and going, well, that's what a lot of women in our generation, that's what we did. I mean, you might not have been a paid athlete, but we went hard for hours, and it was just cardio and beat your body up. And if you're not crawling, it wasn't a great workout. Almost setting aside of beliefs to go okay, I know the research says this. I don't believe this, but I'm going to see if doing something less intense in terms of cardio and just focusing on muscle, what that will do to my body.
So, we have, in our generation, I have 20, 30 years of social conditioning of calories in, calories out, work out more, eat less. And it's still, to this day, I have to I'll catch myself falling into those behaviors again. Have I spent enough time on the treadmill?
Right.
What?
Yeah, yeah.
So, and I love cardiovascular fitness, but I think our generation really ignored our muscle health in general as well in the pursuit of thinness. And what we were probably doing was undermining our bone and muscle strength, which only tends to go down as we age, and it gets harder and harder to maintain. It's doable, but it's a whole different focus than we've ever had before.
From a vanity standpoint, I think the thing that unfortunately that motivates most women is the change in their body. We dismiss all the other stuff.
The biggest pain point in my clinic is the body, the composition changes, and they're so frustrated. And
then you go through a multi-point kind of a toolkit. And your book is phenomenal for this, by the way.
Thank you.
It's a must. Not every woman, but every mother should be giving this to their daughter as well, because we do have a responsibility to the girls who aren't even thinking about perimenopause yet. Like, they don't even want to think about it. They need to know about it in advance. But your book does such a great job of providing a toolkit. Talk to me about diet in particular. You mentioned fiber. What are some other practices?
So for visceral fat, there's some key things. The other is added sugars. So sugars really, through the keto movement, good and bad, has gotten a bad rap, and people were really limiting their sugar intake.
Yeah.
But what happened was they were restricting and avoiding certain foods that happen to be high in natural sugars, which actually the foods that are high in natural sugars are fruits, vegetables, and some dairy. And if people can tolerate dairy, it's fine. And then they were losing all the micronutrients, losing the fiber, when you look at it a different way, when you limit your added sugars, the sugars added in cooking and processing and alcohol, to less than 25 grams per day, those women soar. Those women do extremely well. Insulin resistance scores are lower, less risk of diabetes, and visceral fat is a lot lower.
What do you think about the keto approach for women who are menopausal?
I was a fan for, it's kind of come and gone. And so to be honest, when I first started talking about nutrition, it was for weight loss. I didn't have I hadn't learned enough to know the bigger concept of good nutrition. I wanted to get the fat off, and all my patients wanted to get the fat off. And what can we do to do that? And keto does tend to do that. So for about a year or two, I was all about, low carb, high protein, high fat. However, I was not really doing the added sugar. I was restricting all sugars, not just the added sugars. I would bulk at a berry or something, because I was worried that would take me out of ketosis.
Yeah.
Yes, I lost the fat. I didn't gain any muscle. And so, and I this has been such an evolution in the last 10 years for me of just keep learning and learning from Stacey Sims and learning from Gabrielle Lyon and these people who are really, really doing the work for women's health and the aging, we're aging.
Yes.
In the 50 plus.
Yeah.
And what really works for us, because for years, including the keto data, we were taking studies done on 25-year-old male athletes and extrapolating it out to us. And it turns out it's probably not the best thing for us. We need to be eating more protein, lots of fruits and veggies. Now my plate is plants and protein and fiber.
Same. Love it.
Yeah. I'm that's it, and there's no room for anything else because I love avocado, and it's so packed with fiber. It also has lots of healthy fats and vitamins, minerals, and nutrients. So I'm literally just looking at my plate like that instead of, is this going to take me out of ketosis? Or, is this, I'm am I getting enough protein to grow my muscles?
Yes.
So
what about the approach of intermittent fasting and
so
time-restricted
again,
eating?
pendulum swinging a little bit on that. I was such a fan. I'm still a fan. Let me take that back. And again, the studies, not a ton done on women. I loved the research done by Mark Mattson from the National Institutes of Health on neurodementia and Alzheimer's. Fasting, a daily intermittent fasting, like the 16-8-ish stuff, does seem to lower inflammation for people eating traditional Western diet versus those, so if everybody's eating the same but you're just restricting your window, inflammation does tend to go lower. Here's the problem. People are getting incredibly restrictive and getting really tight windows, and it's hard to eat enough in your tight window. And so for the amount of protein we're trying to get in, it can be a struggle. Where I was a solid 16-hour faster every single day, now my focus is on not breaking when I'm 80.
Yeah.
And I need to eat more protein, and it's hard. I'm basically in an 8-hour window, I was walking around with a chicken breast all day.
Yes.
And it just got to me so much.
Yeah.
And so I'm like, okay, back your window up. So I'm like, shoot for 12. Make sure you're getting your nutritional goals met. And, don't sweat it. There's so many things you can do to lower inflammation. This is just one tool. But if you're struggling to get enough nutrition in your window, then open up your window.
Such great advice.
So
and I love that approach. I think the woman who's watching this, listening to this right now, has been inundated with rules, especially food rules. And, if for any reason you're not seeing the number you want between your toes, well, then you've done it wrong. Then, you did a 16-hour fast, but I bet one of those days you only waited 15 hours, So we beat ourselves up rather than saying, let's have a common sense approach, right? Like the whole intermittent fasting thing, it's not like cavemen were like, we just
noon.
killed a deer, but we've got to wait another hour for my full window. So I like the common sense approach, and I think we need that. We need that amount of grace. Insulin. Talk to me about what happens and why. Why? What's going on with our hormones? Can you explain to us what's causing this shift?
Dozens of hormones in the body. So we need more data. We need more studies, please, in menopausal women. But here's what we think. In the menopause, my friend group who are constantly reading articles and exchanging studies and trying to figure out all the puzzle pieces to this. But so the causative agent, like the first cog in the wheel, is what's going on in our ovaries. So to explain to your audiences, females are different than males in multiple ways. The biggest thing in sex hormones is that men make their sex cells fresh every day. Okay, those are their gametes. This is what's inside of the sperm cell. Okay, and then we have eggs. We're born with all of ours, and they have to last us until they go away. And so a female human is born with about 1 to 2 million eggs, and then we go through puberty, we start ovulating, but they're deteriorating the whole time. There's kind of a clock on them. So we're losing quality and quantity. By the time we're 30, so we start ovulating, 12, 13, 14, somewhere in there. We lose about 11,000 each month in the process of ovulation to get one egg out, okay? Then by the time we're 30, we are down to 10% of our egg supply, maybe 120,000, somewhere in there. And then by the time we're 40, most of us are down to around 3% of our egg supply on average. Perimenopause represents when there's a critical egg level where the signals from the brain, so pre-menopause, when for a healthy woman, your ebb and flow of hormone cycles looks like an EKG. And it's very predictable. Day 4, you're going to do this. Day 6, you're going to do that. Day 14, you're going to ovulate, da-da-da-da-da, and every month looks very, very much the same unless you're pregnant or, have some catastrophe happen. So how does that happen? Why does that happen? Our brain, the hypothalamus in our brain, is constantly checking the blood supply for estradiol. And when the levels get low at the end of your cycle, it sends a signal to the pituitary gland, the other gland, to make some hormones called FSH and LH.
Okay.
Follicular stimulating hormone and luteinizing hormone. Those go to the ovary, they talk to the ovary and say, hey, start ovulating. So there are cells around each egg that start plumping up and pumping out the hormones. So it makes testosterone, which then gets aromatized to estradiol.
Okay.
And it goes up till mid-cycle. At the same time, it's pumping fluid around those eggs. So we have these little cysts forming in our ovaries until one of them pops, the egg flies out, gets picked up by the fallopian tube, pregnancy occurs or not. Okay, and then we have a luteal phase. So then that corpus luteum where the egg came out starts making progesterone for the second half of the cycle. And then that kind of dies off, and then the whole thing starts over again. And that is a EKG-esque, predictable monthly thing. When we reach a critical level of egg supply...
Meaning a critically low supply, okay.
The brain sends the signals, and the ovary's like, I can't hear you. I can't hear you. What? And the brain's like, hey, where's the estradiol? Pituitary's like, I don't know. I sent the signal. And the brain's like, send more. So we get these bigger and bigger surges of FSH. And finally that egg comes out, pop. And we get much higher rises in estradiol and much bigger lows. And the progesterone never quite gets to where it wants to be. So what used to be very predictable is now a zone of chaos. It's a downward trend, but is like a crazy roller coaster on the way down. And we've lost the predictability.
Okay. And when this happens, that downward roller coaster, what systems of our body does that impact? Or maybe a better question is, which doesn't?
Which doesn't, yeah. So as far as we can tell, what we know now and what was like never taught to me in school and what most clinicians don't understand, and that's okay, we're going to get there, is that there are estrogen and testosterone receptors and some progesterone receptors in almost every organ system of our body. So brain takes the biggest hit early.
Brain.
So both cognition and mental health. The neurotransmitters, serotonin, dopamine, norepinephrine, serotonin, all of them change when we lose our estrogen, when we lose testosterone levels. So the way our brain reacts to these changes, and there's estrogen receptors directly in the brain. So not only are neurotransmitters changing, but where estrogen binds changes, blood flow changes. We completely rewire our brain. That book by Lisa Mosconi, she hit the New York Times as well, The Menopause Brain, she goes through this in detail.
Yeah.
It's fascinating. So through that rewiring, we see a massive increase in mental health changes in executive functioning and in brain fog.
Wow.
And it peaks actually probably in perimenopause.
So I wanted to ask you this, because in your book you do such a great job of like explaining this in a way, in plain language. But a question I had is, if a woman had been taking birth control continuous without, so she's never getting her period.
That was me.
Okay. So then do we have more eggs?
A little bit, yes.
Okay.
So when there are things that we know, you take two women, identical twins, and you put one on birth control and one, if they live the exact same life, the one who suppressed her ovulation does tend to go through a small amount, maybe a few months. It's not later. A dramatic difference, but it is a little bit later. If you have never had children and you ovulated that whole time and were never suppressing ovulation, you then tend to lose. A few months, but it's not a huge dramatic amount. Things that we know, genetics is probably the most important thing that will determine when you go into menopause. So those of your listeners who had moms who had premature or early menopause, pay attention. It doesn't, it's not a 1-to-1 correlation because you have half your DNA from your father, but you need to be paying attention and start looking for those signs early.
It was shocking for me to read in your book that women who are, their mothers were victims of
the trauma,
and they were also victims of trauma, how much earlier it sends them into menopause.
Yeah, 7 to 9 years. So huge. That puts you into premature menopause. And so that is the only study that looked at that. And it's such a dramatic thing.
Yeah.
So what she's talking about is women who were sexually abused as children, who then had children who were sexually abused, have lose, almost 10 years off of the life of the ovary. So that is what chronic stress does to the ovary. I'm sure we will find it in other high stress conditions. We just haven't done the work yet. And this particular researcher did the work, and it was just shocking.
So as we enter this stage, right, and I think it's really important that, again, women who are 35 start to recognize, okay, you're declining.
Yeah.
So you need to start thinking about these things and be aware. So we're declining in progesterone and estrogen and testosterone. What about FSH? Like, do we need that? Because I never hear anyone talking about supplementing
FSH is not anything we need to supplement. That is a stimulatory hormone that most of us don't have trouble making. There are a few rare conditions, but most of us have no trouble making FSH. That's actually the hormone we measure to see if you're fully menopausal, because it rises and never comes down for the rest of your life. The brain is always trying to get the ovary to work, but the ovary can't anymore. So that's that key test. The problem is it fluctuates so wildly in perimenopause, we can't use it to make the diagnosis of perimenopause.
That makes sense. So if this is impacting, it's impacting where we store fat, it's impacting our brain, it's impacting our mood, it's impacting our joints, our skin, our hair, everything. What I'm curious about, and the weight, right? Like, so that's a really big pain point for a lot of women who are trying their best. How does this specifically impact ghrelin and their insulin?
So we know that an independent risk factor for insulin resistance, and this happened to me. I've always not had great insulin resistance, but managed it with diet, and I wear a glucose monitor, for this. So, but just going through menopause, the loss of estrogen, the consequential increase in inflammation, we see HOMA-IR scores, which is one of the ways we measure insulin resistance, start trending up, and hemoglobin A1C start trending up. So there will be your listeners out there who are like smacking their heads right now, like, that happened to me.
Yeah.
The other thing that happens is cholesterol. LDL starts shooting up through the menopause transition with no change in diet and exercise, simply from the hormone changes, because estrogen is protective in the liver, and how we make those lipoproteins. It's a more positive benefit, and we lose that protection when we lose the estrogen.
What is your position then on GLP-1s for the menopausal woman?
No, great question. So there's a great study that just got published maybe 2 months ago that looked at women who happen to be on hormone therapy and GLP-1s versus women at the age matched and weight matched, socioeconomically matched. Just and women who were just on GLP-1s in menopause, and women who were on HRT lost 30% more weight. Now, I don't know if they were losing muscle too, probably not. The addition of HRT to a GLP-1 led to a 30% increase in weight loss.
It's been so kind of villainized. There's this like almost moralistic stance that people have about GLP-1s.
I have to say, when I first heard about them being used for weight loss, I was skeptical. I didn't understand the science. And then instead of I'm probably judged for a hot second. And then I started talking to the obesity medicine specialist and opened my mind and was like, oh my God.
Yeah.
We are doing this wrong. Like, it's not perfect. I don't think a lot of patients are being counseled adequately. I don't think there's a worry in my world, in the menopause world, that when just given without proper guidance and management and monitoring, that a woman will be so desperate to get to that number between her toes, she's going to sacrifice her muscle to do it because of the appetite suppression. Women aren't getting enough they're not getting enough protein without a GLP-1, and now we're going to add in things that are suppressing her appetite. And so she's going to cut back. Her calories are going to drop as well as her protein intake, and that's going to chew up her muscle. And so
that's really important.
And I do have patients on GLP-1s, I sat at the feet of some of the greatest obesity medicine specialists and learned everything I could. So in my clinic, I have a body scanner. So I'm able to measure visceral fat and muscle mass in my patients. If I need to, I can send them super easy for a DEXA scan if I need more information or want to look at their bone density.
Yeah.
Why do I care? Well, muscle is what keeps us healthy. Muscle keeps us from falling. The musculoskeletal unit works together, and strong muscles equal strong bones. And, so my patients come in and we take care of the acute stuff. We work on the weight gain. We work on the hot flashes. We work on the things that are like immediately driving them crazy. Then we start setting their course for the next 30 years. We look at their family history. Is your mom in a nursing home? Is she demented? What about your aunts? What about your grandmother? What are we trying to avoid in your family that runs in your family? And so often it is, I want to be able to think and I want to be able to move. I want to be a benefactor to my children and not a burden. What do we need to do? And muscle mass is huge here. So when I'm counseling patients, who are going on GLP-1s to lower their risk of cardiovascular disease, of course they're doing it to lose weight, but ultimately, why are we doing this? So you don't get diabetes, so you don't have a heart attack before, we can delay a heart attack as long as possible, like all the cardiometabolic things we can do with this medication, but we never want to sacrifice muscle or bone to get to a number on the scale, like so focused on that. And we have the conversation about aging.
Girl, you're speaking my language.
And protein intake.
I think all movement is fantastic, so don't get it twisted.
If they're on the couch, I want them to walk.
Sure.
Right.
I think all movement is fantastic, and I certainly don't want to begrudge anyone who's picking up weights and trying their best and maybe watching some YouTube videos. But I also think we've got to get the message out that if it's a pink neoprene weight, you're not building muscle. Right. You might be getting your heart rate up.
Progressive
but there's a big difference between
to
lifting heavy and just lifting weights.
I mean, I'm squatting with a barbell for the first time in my life.
Talk to us about what do we, when you say she needs muscle, what does that mean?
So in order to build muscle, so my patients come in, we're doing their body scan, and she's sarcopenic, meaning she has low muscle mass for her age. She's like at the 10th percentile, 15th percentile,
Yes.
And I'm like, okay, this is going to put you at risk for osteoporosis and for frailty as you get older.
Yes.
It's also going to put you at risk for diabetes because that muscle is a sink for glucose. And the lower muscle you have, the higher risk of insulin resistance you're going to have. So that's another, and it's so hard for our generation. It was hard for me to think, but I need to be on the treadmill.
Yeah.
That's how we stay healthy.
Right.
And I'm like, actually, you need to gain weight and you need to gain about 10 pounds of muscle. And it's a big mental jump for them to think,
right.
And I have people coming in so proud, I'm so healthy, and they are skinny fat. I have to tell them that they have low muscle mass and high visceral fat.
Wow. And so
that's setting them up for...
In a perfect world, like you've got the perfect client, that patient is lifting. You get her to lift how many days a week? Optimal?
I would say start with 2, 3 would be best, but it's got to be progressive loads. So the same 8 pounds you're doing each week is not going to be enough to build muscle.
Yeah,
you know, if you've never lifted muscle, 8's a great place to start. You know, you and I are big fans of the weighted vest. You know, that is such a hack. So I prescribe weighted vests for osteoporosis prevention. Because the studies were done in nursing homes or in long-term care facilities, on elderly women who had osteopenia and osteoporosis, and they put weighted vests. They gave them creatine, another thing I'm super big fan of, and sometimes the vibration plates.
Yeah.
And then they were measuring bone density over time. Now these studies take a long time to do.
Yeah.
Because bone takes a long time to grow, and so 2, 3, 4, 5 years. So they're small studies because a lot of people drop out or die.
Sure.
In the long-term care facility. But it seemed like the weighted vest was really protective of their bones. So I'm like, 10% of your body weight, so 10, 12, 15 pounds, whatever, weighted vest. Walk the dog. Get on the treadmill with it on. Put your treadmill on an incline. I mean, there's a lot of hacks here.
Walk around the house. Do your errands. Move in it.
So I turned my treadmill into a working desk, a walking desk, and I have a little plexiglass thing to put my laptop on. And I'll have it set in an incline, put my weighted vest on, and I'm taking Zoom calls and typing and doing. I did all the research.
This research, we've known about how it can help women from osteoporosis, bone fractures, hip fractures. We've known it for more than 20 years, and there's lots of studies.
Right. And
but I'd love for anyone who's listening to this to comment below if your doctor, because I had the beginning 8 signs of osteoporosis, and my doctor did not recommend a weighted vest. He recommended a medication. And I don't think most physicians know this information. They're just like, here's a statin, here's and there are definitely places for these medications, but I think we're missing the boat for like proactive counseling. And, the status quo is that you go through menopause, you don't get a hormone therapy, and then so we live longer than men, right? 3 to 4 years, depending on who you read. But we live 25% of our lives in poorer health than our male counterparts. And we are 3 times more likely to end up in a long-term care facility. Not because we're living longer, because we're less healthy. Yeah.
And that's the status quo. And that's what the Menopause is locking arms to fight. And it's not just hormones. It is how much money we're putting into studies. Looking at, for example, cardiovascular disease. Statins are routinely given out like candy to women with high cholesterol. 80% of women will have an elevated cholesterol after menopause. Okay? New for her. And, here's your statin, bye. Tons of side effects, okay? It will lower her cholesterol, but it won't decrease her risk of a heart attack, a primary first-time heart attack. It will not decrease her risk of death from cardiovascular disease, yet it is routinely recommended. That only happens in men.
And as I understand it, those studies didn't actually use women in the studies. It's
not
all
very
men.
many. And so there's a few, but vastly, most medical research, it wasn't until 1993 that women were forced to be included in studies, and we're still not 50-50. And then McKinsey and Company they were doing a research paper on menopause in the workplace and what the economic impact, because 1 in 5 women in the UK and probably in the US quit their job because they can't function at work, mostly from the cognitive changes. So
what impact does that have on marriages?
But when so 1 in 5 women quit their jobs, and
just because of the stuff that's happening in their brain and their bodies, and also
loss of executive functioning.
You don't want to talk about it,
no,
because there's so much stigma around even the word menopause and perimenopause. I know myself when I was having symptoms and even treating with the doctor and doing some early hormone support. I remember thinking, well, I'll do this, but I'm not even close to needing to worry about menopause, even though now in retrospect, I realize those are all perimenopausal symptoms. So we've talked about diet, right? And you've talked about some of the strategies that really work and things that we need to change because our hormones are different. So we're combating that, right? You've talked about how we need to also change our exercise. We need to change a lot of things that once we're working, won't work for us now. And I know we can talk about like natural remedies, which your book has so many great options there too, because there is a lot of still fear around any type of hormone therapy. But for the woman who is a candidate or is at least open-minded, wants to know more about it, I know you say it's not a magic bullet.
No.
But how does it benefit us?
Sure. Well, the best thing I could ever do would be to transplant your 25-year-old ovaries back into your body, but that ship has sailed for us. So hormone therapy is great, and it has so many benefits, but it's not your 25-year-old ovaries. So I don't want anyone to feel like it's gonna reverse the clock, the time clock. But we are aging. We are still aging. But what are the known benefits of hormone therapy? 85 to 95% of vasomotor symptoms will disappear with HRT. So that's hot flashes, palpitations, night sweats, that kind of, and then sleep disruption associated with those symptoms will get better. And for a lot of women, they're getting their life back. So that's huge. So if you sleep, your cortisol level goes down, your inflammation levels go down, you tolerate sugars better, your insulin resistance goes down, or improves. And, that's one of the top things. You will have stronger bones. You will slow down the rate of osteoporosis happens because we start chewing up bone faster than we're laying bone down. You don't have the same bones you had 20 years ago. We constantly remodel our bones, which is why when we break them, they get fixed naturally. We don't have to do anything other than set the bone. Yeah. Because we're always chewing up bone and laying down new bone. But after menopause, and after about 35, the chew up part accelerates and the lay down part slows down. But that just goes cattywampus for most of us in the menopause transition.
Without the hormone support.
With the
hormone support, you're seeing better bone density.
Better bone density.
What about muscle development?
So women it slows down the loss of muscle with aging if you maintain your estrogen, especially your testosterone level.
Is it fair to say that hormone support, hormone therapy, isn't a magic bullet, but it certainly helps to level the playing field?
Right. So what I tell patients is, you can be healthy without HRT. It's just harder. So think of it that way. Absolutely, you can do it without it. You can live a long, healthy life and not have dementia and frailty and just die whatever your natural cause was going to be in your 90s. But it is a lot harder.
I want to play devil's advocate for a moment. The Women's Health Initiative, that science has been walked backwards, right? And so
the data's still there. It's just been reinterpreted.
It's been reinterpreted. What are the risks that we could have all of this information walked back and we change our interpretation of it 5 years from now or 10 years from now and go like, oh, maybe we shouldn't have been supplementing hormones?
And I'm quoting, I think, Peter Attia on this one, but, this is probably the biggest mess up in the history of medicine in our generation is the way, it was the biggest medical news story of 2002. It was on the cover of every major magazine, every major newspaper, all the morning shows, all the evening news, and it scared the living out of women and their doctors. And that notion of estrogen causes breast cancer, which it does not. Okay, I don't take a healthy breast cell and put it in a petri dish and dump estrogen on it and it's going to turn malignant. That's not how it works. That's biologically implausible. And just let's use a common sense approach. Our estrogen levels are absolutely the highest when we're pregnant.
What about testosterone? There's so many wonderful experts to follow online.
Yeah.
I think you in particular have done an amazing job with your social media of spreading the word. Millions of followers. I discovered you during the pandemic, just watching you on TikTok and going, why aren't I hearing this anywhere else? But there does seem to be this kind of division over testosterone.
Right.
So what's your position on the latest research?
I'm a huge fan. It's a human hormone, and it declines in menopause, not the amount of estradiol, but definitely it declines at least 50% once you go through the transition. And again, like estrogen, there are testosterone receptors in our brain, in our bones, in our muscles, in our genital urinary system. I was a little late to the party for getting on board with testosterone, but you can't refute the evidence. And then as the Menopausal has grown, which is the other healthcare providers, clinicians that we all lock arms.
What do you call it? The Menopausal?
So it is this group of clinicians, mostly female. We have a couple of good men who are so focused on bringing care of the woman after reproduction into the forefront, making it important, putting pressure on academic societies, putting pressure on boards of medical institutions so that, and on legislatures, so that we can get funding, so that we know how to keep a woman as healthy as possible for as long as possible. And that's not what's happening right now. So testosterone. Great studies on hypoactive sexual desire disorder, which your followers would probably call low libido.
Sure.
So let's talk about sexual function, just like a high level. We have kind of 5 buckets that a woman can fall into when she's complaining of, I'm not happy with my sex life. So 1 is a relationship disorder, and I can't fix that with medication.
Right.
You are not connected to your partner. You're not probably in a long-term relationship. You are not probably going to want to have relations with them.
Right.
And so that's counseling or find a new partner or whatever. So move that one out the way. Then we have orgasmic disorder, arousal disorder, different things. So people who struggle, and we see that a lot in menopause, delayed orgasms, lack of an orgasm, or loss of the peak of the orgasm. They're not as strong as they used to be.
Yeah.
And that a lot of that's due to blood flow, different innervation, as things become less healthy in the area from menopause, and there's medications that can help. Then there's desire disorder. That's in the brain. That is your brain being receptive to that, whatever that stimulus is for you, where 10 years ago that would have interested you, but now you just want to go to bed. And so what can we do about that? And 1, we have to normalize, for some women that's okay and that doesn't bother them, and that's okay. But if it's affecting you and you miss it, and it's affecting your relationship, then, and you want to do something about it, testosterone therapy is really powerful in the menopausal patient. Now, we do have 2 FDA-approved medications for desire that have only been studied in premenopausal women, but we're using them off-label. So 1 is Addyi, and these companies don't pay me anything. So 1 is Addyi, ADDYI, and the story of how Addyi got through the FDA is really, really a great story. If you don't follow Cindy Eckert, she's amazing.
Yeah.
She developed it, and, when Viagra went through, it was like an FDA emergency. It had one of the fastest times in the history of the FDA of being approved.
Right.
And Addyi was like years and years and years, and they kept denying it. She kept coming back with more data. So it has a modest effect on, sexual encounters that are pleasing to the patient. The other is Vyleesi. It's an injectable. It works on melanocortin in the brain and you give it about 30 minutes before relations. So most of my patients are a little hesitant to try that one. It's expensive, and their partners, they feel like, would be like praying mantis. Like, is it working? Is it working? Is it working? Right. But, for people who have a good response to it, they love it.
Don't you think we've done a real disservice by making the conversation about testosterone so centered around libido?
Right.
I mean, I think about what it's done for just having my levels where they should be. Not anything crazy, but just to maintain where I felt my best before they started to decline. What it's done for my strength, what it's done for my brain cognition, what it's done for just feeling vital again, feeling like clear. And I guess, which probably helps with body fat, I would assume.
So women who have the highest, natural levels of testosterone. So we don't have a lot of studies looking at bone and muscle strength in giving a woman testosterone therapy. We look at, they happen to have testosterone levels drawn, and what was their muscle mass? What was their visceral fat? And so women who naturally kind of were on the higher end of things were healthier. Brain function, muscle strength, osteoporosis. So for that, many of us are off-label considering testosterone therapy for patients who have osteopenia it doesn't work in a silo. You have to lift the weights, you have to do the work.
Yeah. But
it's part of the toolkit that you might want to consider if you are trying to get stronger and improve your bone and muscle strength. It also has genital urinary receptors. So the people in ISWSH, which is the International Society of Sexual Wellness for women, are really fans of testosterone, especially in the vulva. For patients who are struggling with genital urinary syndrome of menopause. So here's the problem. We don't have an FDA-approved version. Thank you, FDA. We'll call out to them for testosterone therapy for women. So we have 2 options. Try to get her the men's version, and she has to use 1/10 of the dose typically. Sometimes that's hard to titrate with these packets and gels because the man just takes the whole packet. A woman needs 1/10 of the packet, a pea-size amount. So, or they come in tubes too, and that one's easier to measure. Or we compound it. So where I practice in the state of Texas, there's no one who likes to get more involved in the healthcare of a woman than a Texas state legislator, than a Texas state pharmacist.
Oh, really?
So we get a lot of pushback from the pharmacists when I try to do the men's version. It's never going to be covered by insurance because it's not FDA approved for women. But there's just this it's either a form of shaming of, why do you want to have an improved libido? Just, or are you transitioning? So it is FDA approved for a female transitioning to a male. And so women feel, because they get asked directly, are you transitioning?
Not transitioning into menopause.
So not for their menopause transition. So psychologically, to avoid a lot of that, I end up compounding for quite a few patients from a local compounder, a cream that they just rub. I usually have them rub it into their thighs every day, and the results are great. They're so happy. They feel it's just such a powerful tool for so many of them in their toolkit.
Yeah.
But, not everyone's on board.
Yeah.
So the Menopause Society recognizes the data in hypoactive sexual desire disorder and refers to ISWISH for dosing for your patients.
Yeah.
But right now it's not covered by insurance for any woman.
Dr. Mary Claire Haver, why did you decide to title your book The New Menopause? What do you mean? What's new about menopause?
Yeah. So there's kind of two schools of thought from what I've found in the menopause world. Forever the status quo for at least the last 23 years, especially since the WHI, since hormone therapy was taken off the table for many, many patients, what can we do for them? So if we don't have a treatment, why would we even address, right? And this is just your fate in life. You're going to have dementia much more than your male counterparts. You're going to have frailty.
Deal with it.
You're going to have visceral fat. You're going to have a cardiovascular disease. I mean, the number one killer of women is cardiovascular disease. And so the new menopause ended up being inspired by a group of clinicians who refused to accept the status quo and said, we can do better. We deserve it. Our patients deserve it. And we have the data to back it up. And so one of the frustrating things for us is that from a research publication to getting into a society or a board and having the guidelines changed, then those are now accepted in clinical practice on a routine daily basis is usually 17 years. So we are a generation away from you being able to walk into whatever primary care OB-GYN's office, OB-GYN, and saying, I'm menopausal, I'm having X, Y, and Z symptoms, and having an informed conversation that involves a full discussion of hormone therapy.
We're a full generation away from that.
I think so. So for now, we have Band-Aids. Go to the Menopause Society, find a certified provider. Still not perfect, but better than just randomly going into any healthcare provider's office. Because the studies have been done, maybe 6% of OB-GYN residents today feel comfortable discussing menopause and hormone therapy with their patients. 6%. And right now, before the WHI, about 40% of women had chosen hormone therapy, not only for the hot flashes, but also for the protective benefits. It was recommended by multiple societies for the protective benefits of bone, brain, and cardiovascular disease. We know that if you start in the early window of opportunity,
which is what?
Between 50 to 59. Doesn't mean you're not a candidate after, but the earlier you start,
even
the
before
more
50?
Protective it is.
Okay.
Yeah, if you start in perimenopause, the cognition is going to be much better as well as the mental health changes. Actually, the newest data, I just went to a symposium. There were 2 neuroscientists and 2 psychiatrists that were talking about mental health changes and cognition changes in menopause. And they said very clearly the data is saying that in perimenopause, hormone therapy should be primary treatment for depression.
Wow.
For a female.
I could have you here for hours, but I would be remiss if I didn't ask you this question because I know we've got women who are listening, who are watching on YouTube they're postmenopausal. And she's 55, she's 65, maybe she's 70.
Yeah.
And she wants to
know. Is it for me?
Am I still a candidate?
So for those patients, symptoms or not, it's always going to protect your bone. It's always going to protect your general urinary system. Now, we can do local therapy for that, vaginal therapy. And that's
And when you say vaginal therapy, you mean a vaginal cream?
Vaginal creams, there's pills, creams, there's a ring now, suppositories. So the vaginal options are zero risk. Everyone, even with an active tumor that is estrogen receptor positive, can use it safely without any worries of recurrence or worsening disease.
Did you hear that, Mom?
So that's a separate conversation, but I want everyone to know that they're a candidate for vaginal therapy, and you should be on it because it will decrease your risk of recurrent UTIs and urosepsis by 50%.
Wow.
How many of your mothers ended up in the ER in the hospital with urosepsis, with a UTI that turned into sepsis? We can avoid half of that and save Medicare billions a year by just giving vaginal estrogen to everyone to keep the tissue healthy. But what about systemic therapy, okay?
Okay.
So for those patients, I'll do a workup. I will say, all right, what are your risks for cardiovascular disease? Because we don't want to put estrogen on, and this data is changing a little bit. Right now, the thought process is if she has existing cardiovascular disease in the form of atherosclerotic plaques, hormone therapy might make that disease worse. So we don't want to do that, okay? So we work that up. What's her cholesterol? What's her blood pressure? What are the risk factors for cardiovascular disease? If they're elevated, I'm getting a calcium cardiac score, a CT of the heart, where they're measuring calcium. They're looking for calcium deposits within the coronary arteries. Sometimes we can get ultrasounds of the carotids, the blood vessels that go up to the brain, to see if the intimal thickening, if they're thinner, and that's from the plaque buildup. And so we have ways to see, is she still healthy? Does she have risk factors? And if she doesn't, then we start the conversation around risks and benefits for the patient. So I'm not automatically denying a patient over 60 access to hormone therapy. It's a nuanced conversation.
Yeah, and it all is very nuanced. Thank you for your multi-pronged approach. Thank you for being such a champion of this message. Like I keep saying, menopause is having a moment, and so much of that has to do with you because you were just so vocal and not afraid of people who disagreed or thought they were know-it-alls or whatever, because you really do care about women's health. And I love that a big piece of this is for your daughters, right? If there's one thing that you think every woman needs to hear before menopause, one piece of advice, what would that be?
Menopause is inevitable. It's not optional. It happens. If we're lucky enough to live long enough, it's going to happen to all of us. But suffering is not. And there's no amount of suffering you have to tolerate in order to qualify to go into your doctor to be taken seriously. And we do have a lot of work to do, and I'm working on that. I'm using this big voice God gave me on social media to try to, have things work from the inside. But I'm also trying to give you tools to be able to advocate for yourself.
Congratulations on your book. I recommend everybody pick it up. Where can people who want to learn more from you, where do you suggest they go?
So we have a website called The Pause Life. And it's full of quizzes and information and blogs of, just at your fingertips of just little tidbits and how to find a doctor, what to ask your doctor, what lab tests you might want to be recommended, just so that you can get the most out of your visit for your overall health. We have information on bone density and muscle strength and, all the things we talked about in the podcast today. You can find me everywhere on social media. We have Instagram, YouTube. YouTube videos are longer, Instagram, TikTok, and Facebook.
Now, if you want to learn more about testosterone, I think you would love this episode. If you're trying to figure out how exactly to modify what it is you've done in the past for your exercise and you need to change that up and you want some support, I think you'd love this episode. And if you want to see my full playlist of workouts you can do here on YouTube, check this out. You're amazing. Thank you so much for being a guest here on the Chalene Show.
Thanks for having me.